you that you are attending a second international conference, Cancer Metastasis. And this conference is entirely virtual conference this year. So we are close to start the evening session of the first day of our meeting. And our first speaker for the session is Professor Yona Keisari from Tel Aviv University. And Professor Keisari is emeritus in clinical microbiology and immunology. And today he will talk about specific anti-tumor immunity induced by diffusing alpha emitters radiation, inflicted tumor damage, and its amplification by immune modulation. So we are very much looking forward for your exciting talk.
Thank you very much, and good afternoon and good morning for those from the US. Thank you very much for participating. And today I'm going to talk about a new or a relatively new modality of alpha radiation, and how it is integrated with immunomodulation and other anti-cancer modalities. We all know that the treatments, the regular treatments for cancer are surgery, radiotherapy, and chemotherapy, also biological therapy. And the major problem with cancer is, of course, metastasis. Almost 75 to 90%, depending on the tumor, death which are caused by cancer are due to metastasis. So this is the major problem that we have to deal with. And I will show you how it is related with radiation. Radiation therapy is a very strong tool for oncologists and for the treatment. And about half of all cancer patients in Europe and about 2/3 in the US receive photon radiation as part of their treatment of cancer. But there is no alpha radiation-based treatments for solid tumors. We know external beam radiation, brachytherapy, which is intratumoral gamma radiation, and targeted radionuclides, some alpha particle-based treatments with targeted alpha radionuclides, but not with alpha radiation for solid tumors. And what is the problem? The problem with alpha radiation is that the range of the alpha particle is about 100 micron in tissue. So from the practical point of view, it cannot be used as external beam. So in Tel Aviv, Professor Tzchak Kelzon and myself, we developed a new treatment with alpha particles, which is called diffusing alpha particle emitter radiation therapy. And I will show you what is the principle of this treatment and how it is used in the treatment of cancer patients. So the principle is the following. We take thorium-228 and we milk it to get radium-224. This radium-224 we load on metal seeds, and these metal seeds are inserted inside the tumor. When they are inside the tumor, the radium starts to decay, and the first product is radon-220. By recoil force, the radon-220 is pushed out from this metal seed and is entering into the tumor itself. Now there is a chain of decay which end up with non-radioactive lead, and on the way, the daughter atoms release alpha particles and some beta radiation into the tumor. But meanwhile, they diffuse inside the tumor. The overall half-life of these products is about 12 hours. So this is the time they have to spread inside the tumor. So what do we have? We have a pump of radium-224, which with a half-life of about 4 days is pushing radioactive alpha-emitting radioactive atoms into the tumor. And we started with this idea about 20 years ago, and I'll show you how it developed. So first of all, of course, I will show you that it is really a practical idea, and what can we do with it. But actually, our major say aim was to develop the alpha radiation-based treatment as a platform to compose combination treatments which will treat both local and metastatic disease. And during the years since 2003, we examined the effective destruction of solid tumors lesions. We studied the scope of the effect of this treatment on various tumor histotypes. We looked at the mechanism of activity, spread of radioactivity, DNA damage. We also were very much interested, of course, in the induction of systemic anti-tumoral immunity. And we wanted to know if we can combine this modality with other treatments, other tumor treatments. And of course, the final goal was to conduct feasibility and safety clinical trials. During the years, we worked with thousands of animals with various types of tumor tissue, and we found that we can actually kill all tumors that we treat, whether they are from mouse origin or whether they are from human origin. These are a few examples. Here we can see squamous cell carcinoma in a mouse, and after treatment, the tumor was gone. Here, believe me, was a tumor, this kind of tumor, and the tumor disappeared. But not only did the tumor disappear, please also notice that there is no damage here. This is a glioblastoma that was treated by our radioactive seed, and this is a human prostate tumor that was implanted in nude mice. In order to find out whether the idea or the concept of spreading radioactive atoms in the tumor is true or is correct, we took tumors and inserted a radioactive seed here in the middle. After several days, we took out the tumor, we sliced it, and we measured the spread of radioactive atoms. And now you can see that we have here alpha emitting atoms in a range of about 5 millimeters. If you remember that the range of an alpha particle, if it's emitted directly from an atom, is 100 micron or less than that, this is a very important improvement. And you can see here on the left panel that all the area that was exposed to the alpha emitting atoms is now destroyed and tumor necrosis occurred. If we use these seeds in a larger tumor and we insert several seeds, we see that each one of them is making a radioactive zone, which is causing destruction of the tumors. And this is actually the basis for the treatment plan that we use in cancer patients. We were interested in the mode of action of these atoms, of these alpha emitting atoms. And we found that they will cause double strand breaks in various tumor types, but we found that there is a range of activity from squamous cell, pancreatic cells, and breast carcinoma cells. Some tumors are more resistant and some are more sensitive. We concluded that the differences in the response of various tumors to DART is dependent on the spread of radioactivity inside the tumor, the sensitivity of the cells to alpha radiation, and to the rate of clearance of the radioactive atoms from the tumor. After we were convinced that the radioactive seeds, the radium-224 loaded seeds, they can kill tumor cells and can actually destroy solid tumors, we were interested in actually improving this effect. And we thought that there will be two approaches that we should take. One is to increase the local tumor control. maybe by sensitizing the cells to the alpha particles by effects on the DNA. We can do that also by inhibiting DNA damage repair, or we can use metabolic agents which will promote tumor cell killing, and I'll show you several examples for that. On the systemic level, we also aimed to treat, of course, metastasis. And for this purpose, we asked if we can combine that with neoadjuvant chemotherapy, with anti-angiogenic therapy, and of course, activate anti-tumor immunity. This is just an illustration of what I just mentioned. So just to give you a preview, we found that we can destroy solid tumors by alpha radiation and stimulate anti-tumor immunity that will kill the tumor cells and will also be effective against lung metastasis, which is called the Abscopal effect. This is an effect that we also wanted to boost. And how can we do that? We can do that either by activating the dendritic cells with immunostimulants, or inhibit suppressor mechanisms like myeloid-derived suppressor cells, or T regulatory cells, or checkpoint molecules. And I'll show you examples of each one of them. The agents which we used for this purpose were of two types: molecules which enhance immune response, adjuvants like poly-IC or CpG, and molecules which inhibit the suppressor cells, like cyclophosphamide, inhibitor of T regulatory cells, or sildenafil, which inhibits myeloid-derived suppressor cells. Excuse me, but I am afraid that I missed. Yeah. Okay, I will use this one because for some reason, some of my slides are not showing properly in the other mode. So the first thing that we wanted to find out was, if we destroy tumors by alpha radiation, will that cause activation of anti-tumor immunity? So we took colon cancer cells, injected to mice, treated them with alpha radiation, and after destruction of the tumors, we re-injected the animals with another dose of tumor cells. And we found that if we destroy the primary tumor with alpha DART, the animals became resistant to a challenge of tumor. This was evident if we compare it to tumors that we removed just by surgery. This one I talked already. And so we came back to the colon cancer model of our cells, and we took mice. We injected them with colon cancer cells, and then we treated them with alpha DART seeds with CpG, sildenafil, and cyclophosphamide. And we found that without any further intervention, we could rescue 50% of the animals from the disease. We took the animals that were cured and we checked their resistant to another tumor challenge, and we found that 100% of them were resistant to the colon cancer cells, but not to another tumor cell, which was a breast carcinoma. We also did a passive transfer with lymphocytes from the cured animals, and we found that that lymphocytes from colon cancer cured mice were protective against the colon cancer cells, but not against the breast carcinoma cells. Another model that we used, more aggressive and more metastatic, is a breast carcinoma. Here, we were also able to show that all tumors start to regress. 30% completely disappeared, but some of them returned and regrowed. But in this model, which is a metastatic model, we found that we can actually inhibit or eliminate lung metastases, which were present in the lungs of the animals in which the tumors were growing. Another agent that we used for immunostimulation is poly-IC that is actually coupled with another agent which is called polyethylene. And you can see that the primary tumor was very highly affected by the combination of that and the immunoadjuvant, and this is the control. But in addition, we found that in the lungs of the animals which carried the tumor, the metastases that are present in the control animals were actually eliminated. This is just a repeat of the same experiment with other tumor cell types. I will not elaborate on that. But what was very interesting to find out that if we use the radioactive seeds in combination with poly-IC and the inhibitor of T regulatory cells, we were able to rescue 80% of the animals from death from lung metastasis. This is a 41 tumor cell type, which is comparable to a triple negative breast carcinoma and is very widely used in different experiments. So actually, I showed you so far that we can use the intratumoral alpha radiation seeds in combination with immunological stimulators and immunological immune manipulating agents to cure both the primary tumor and metastasis in such animals. The next thing that we wanted to find out is if we can combine alpha DaRT with other anti-tumor measures like chemotherapy, agents which inhibit DNA damage, or agents which interfere with cancer cell metabolism. Using DaRT with gemcitabine was very effective in inhibiting the growth of pancreatic cancer cells in animals. And we also showed that to be true for squamous cell carcinoma, which the combination of the alpha radiation and the chemotherapy extended the survival of these animals very significantly. Another agent that was of interest for us was an agent which is known to change the conformation of DNA. The cytarabine is an agent which is used for the treatment of cancer and is known to change the methylation of the DNA proteins, or the proteins which are around the DNA, and is known to sensitize tumor cells to radiation. So we used the DaRT in combination with the cytarabine and with the immunostimulant. And by doing that, we were able very effectively to inhibit the growth of the tumors and also to cause elimination of lung metastasis and extend the survival of these animals. Another agent which was of interest for us is an agent which will actually inhibit angiogenesis. It is very difficult to use anti-angiogenesis agents at the treatment of cancer because of the side effects. But here we have a window of treatment in which the tumor is actually destroyed by the alpha radiation. And when the tumor is destroyed and attempting to revascularize and regrow again. If you will use an anti-angiogenic agent, maybe you will be able to eliminate the growing cells and cause complete eradication of the tumor. So we did such an experiment. We used pomalidomide as an anti-angiogenic agent, and the combination of that with immunostimulation and with the anti-angiogenic agent, we were able to rescue more than 50% of the animals and cure them completely from the tumor. So I showed you so far that the alpha radiation-based treatment can kill a large variety of tumor cells, both derived from mice and from human. We can stimulate the specific anti-tumor immunity, which can be enforced to facilitate tumor elimination. And we can use a combination of that with radiosensitizing agents and chemotherapy to achieve a higher cure rate of metastasis, of metastatic tumors. So the next step, of course, was to go for the clinical trials. The alpha radiation-based treatment has several advantages over photon radiation. First of all, it does not rely on oxygen, so it can work effectively against hypoxic tumors. It has a very low gamma emitting or photon emitting energy, and therefore it's safer for the physicians and for the patient. The seed is very simple to manufacture, and therefore it offers a great variability for tailoring the treatment for the patient, for the type of its tumor, and for the size of its tumor. And in addition, we can actually use the alpha radiation in combination with other treatment modalities. I'll show you several examples of treatments that we gave to patients. And we first started with squamous cell carcinoma, an experiment that was performed in Israel and in Italy. This is the first patient. Here, the tumor here on the cheek. It was a recurrent tumor. The seeds were inserted into the tumor and were left there for 15 days. This is a CT scan of the tumors, of the seeds which are inserted into the tumor. This is a patient who had a squamous cell carcinoma in the ear. His tumor was treated several times and he became gamma radiation resistant, and the physicians wanted to remove his ear. So he came to the clinical trial, and Professor Popovtzer from Rabin Medical Center inserted the seeds into the tumor. After 15 days, the seeds were removed, and after 3 months, inspection showed that there is no tumor in this location. This patient was treated almost 4 years ago, alive with his ear intact. This is another patient which is suffered from a tumor on the skull, was very difficult to treat, and the physicians inserted the seeds into the tumor, and after 1 month, or after 15 days removed, and this is what after 1 month. So the tumor not only disappeared, but also you can see that the tissue is completely recovering after the treatment. I should mention that we treated a patient which was 102 years old, that nobody wanted to treat him with any other measure, and we gave him this treatment without any damage, and the tumor was eradicated. This is an interesting case that was treated in Italy with a patient who had 3 lesions. One of the lesions was treated with alpha radiation, and after 1 month, they wanted to treat the 2 other lesions. This is one of them, but the inspection showed that these lesions disappeared. We suspect, although no direct proof for that, that this was because of the anti-tumor, the immunity that developed after the eradication, after the treatment of the first tumor. The overall study, which was published almost a year ago, showed that we have, after 1 month, close to 80% response in the patients. After another year, about 61% of the patients remain tumor-free and alive. This is the distinguished list of our collaborators. We have now experimental sites in the United States, in Canada, in France, in Italy, in Moscow, and in Japan, and ongoing experiments are all over the place. And this is the important group of people who did the preclinical work, most of them the PhD and MSc students of Professor Curzon and myself. And I should point out the contribution of Dr. Leo Arazi, Tomer Cooks, Ila Confino, and Michael Schmidt. And most of them are still working in this, on this project. And thank you much for your attention.
Thank you very much, Professor Keisari, for your very exciting talk. I think we still have 4 or 3 minutes now. Actually, probably it's time for 1 or max 2 questions. I would like to ask you, what is your opinion? Is this very interesting and promising type of treatment with alpha emitters excellent only for superficial tumors? Or you can also imagine, because I think the range in tissues is quite limited, like to few cell diameters. I think it would be very exciting approach for treatment of, let's say, like a single dormant cells or for eradication of small metastases. Can you imagine further development of this approach, that even small metastases in size of the body, which is hard to reach, can be treated with alpha emitters?
Well, actually, there is one clinical trial which will soon start in Canada, where they are going to treat pancreatic cancer with these alpha radiation seeds. We plan a treatment for lung carcinoma or lung metastasis, also in New York. And we are now in the stage of recruiting patients with prostate cancer for the treatment with alpha radiation. So we have, and we also develop various types of applicators that will enable us to insert these seeds, which are relatively small. They are about 1 centimeter in size. It will enable us to insert these seeds anywhere in the body, either directly or via different catheters.
Very exciting. So I wish you all the best with your clinical translation. Looking very much forward for the result of these trials. Thank you very much once again. And I think we need to move to our next speaker of this session. So our next speaker is Dr. Silvia Formenti, who is the chairman of the Department of Radiation Oncology at Weill Cornell Medicine. And Dr. Formenti will talk about state-of-the-art in combination immunoradiotherapy, hunting for abscopal effect. So we are very much looking forward for your talk, Dr. Formenti.
Thank you. Good afternoon. I hope you can see my screen well. Let me get started.
Hear you, we can see your screen.
Yeah. So these are my disclosures, and particularly I will discuss the use of ipilimumab off-label. So approximately 20 years ago, we came up with the idea that radiotherapy can in fact convert the irradiated tumor into an in situ vaccine. And the idea is that modification induced by radiation, both cell killing and other changes sensed by the tumor microenvironment could in fact generate an inflammation that is sensed by the immune system, both with stimulatory signals as well as immune suppressive signals. And if that balance was in favor of immune stimulation and cross-priming, it could mount an immune response that in fact affects not only the primary tumor, but also through immunological memories, also out of field distant sites, the so-called abscopal effect. And this idea of the abscopal effect is an old one that has surprised many radiation oncologists, and is based on the fact that when you radiate one tumor, not only you see an effect in the field of radiation with disappearance in some patients of the radiated tumor, but also you may see outside the radiation field, where only very low scattered dose is arriving, another response, a response that is not directly induced in the field of radiation. However, while reported in 1953, these effects are extremely rare. Over 45 years, only 46 cases were found by a very careful review of the literature, at least reported in the literature. And it's not a surprise that these effects are rare, because for the time cancers are established, particularly in the metastatic setting, there is robust immune suppression that enables their growth and in fact permits the evasion of the immune system, whether it's through editing and immune selection of poorly immunogenic tumor cells, the recruitment of immune suppressive immune cells, or even at the systemic level is the release of soluble tumor-derived products that inhibit the anti-tumor immunity. And then, of course, at the cell level, the development of, the induction of checkpoints that block immune recognition and rejection. And as you know, a lot of drug development is occurring in this field with specific antibodies that target these immune checkpoints, whether it's CTLA-4, PD-L1, or TGF-beta. So over the years, we have been trying to interfere with some of these mechanisms, whether by enhancing the positive effect of radiation with toll-like receptor agonists, growth factors like dendritic cell growth factors, inducers of interferon or IL-15 and so on, or by blocking the negative effect by interfering with CTLA-4 induction, or blocking TGF-beta, CD73, VISTA, activin, and so on. In each of these cases, we were able to show quite successfully preclinically the synergy of radiotherapy, focal radiotherapy with this immune checkpoint or immunological manipulations. And sometimes we were able to translate it to the clinic. And
so approximately 15 years ago, we were most fortunate.
And this was done initially with in a mouse model that we developed with the help of a monoclonal antibody that we had received from Jim Allison against CTLA-4. But what we next did was to move into studying the mechanism. And Claire Van Puy-Box, which was doing her postdoc in our lab, decided to really look at the dose dependency of this effect of radiation, and particularly the induction of type 1 interferon. And she was able to show at gene expression that in fact, there is really a difference in terms of the induction of type 1 interferon when you use a single dose of 20 gray versus a fractionated dose of 3 times 8 gray. And why so important looking at type 1 interferon? Type 1 interferon in experience of multiple labs and now consolidated evidence has shown to recruit to the tumor site a specific subset of cross-presenting cells, dendritic cells, the BAF3 dendritic cells that are capable to cross-present very efficiently in tumors and in fact induce an immune response. So the model is that very similar to the DNA of virus, radiation-induced fragments of DNA stimulate through the sensor of CGAS stings the induction of interferon. Interferon recruits these dendritic cells that in fact are undergoing maturation and develop and are capable to do the cross-priming through neoepitopes that are released during cell killing by radiation. And in fact, when combined with the blockade of the immune suppressive effect of radiation, so by blocking CTLA-4, you can in fact generate an immune response that not only attacks the primary tumor, but also the abscopal at distance tumor. And then when Lorenzo Galluzzi joined our group, he was able to show that the mitochondrial DNA is also crucial to induce these effects, to the abscopal effect. And in fact, he had a mechanism to block the induction of interferon by blocking by generating this mitochondria DNA depleted raw zero cells, and showing that in fact when you use this mechanism, induce these cells, you reduce drastically the production of interferon and abrogate the abscopal effect. So it's very important also the DNA that comes from the mitochondria of cells, not only from the nucleus. So all of this nice, but now it needs to be translated to the clinic. And that's what we tried. And we had a first very crucial case of a patient who presented with multiple metastases all over the body. To our attention, he had progressed after 3 lines of chemotherapy and chest radiotherapy, had refractory metastatic non-small cell lung cancer. And he had come to us for palliation of a bone lesion, as a matter of fact, but he had read our work in preclinical work in mice with anti-CTLA-4 radiation, and we elected to give a radiation to just 1 metastasis in the liver and obtain a special permission from the IRB to treat off-label with ipilimumab these patients, 3 mg per kilogram, even in a disease where the drug was not approved. And what we were able to show that not only he had a beautiful response of the tumor in the liver, but also his metastases that are regressing. And here he is 8 years later, almost 9 years later, just recently when he came in follow-up, and he just received a total of 6 cycles, 4 cycles during around radiation and 2 after radiation for consolidation of anti-CTLA-4 ipilimumab, and no other treatment, no anti-PD-1, nothing, and has been in remission for such a long time. So this patient inspired us to design a protocol for similar patients, and we're able to obtain as a gift ipilimumab from Bristol Myers Squibb. And we tested this hypothesis just by metastatic refractory non-small cell lung cancer that had grown after radiation and chemotherapy. We could just irradiate 1 lesion and pulse ipilimumab. I want you to recall that ipilimumab alone has really no efficacy in this disease, very low level of response rate, less than 5%. Well, by irradiating just 1 lesion in this setting, and these were heavily pretreated patients, we were able to demonstrate, based on intent to treat, 18% objective response rate. And this was despite the fact that many patients, 40% presented with evidence of brain metastasis in this series. So somehow radiation reposition in the setting with this entity of response rate, which is comparable to anti-PD-1, which is much more effective, anti-PD-L1 set of drugs in this disease, when you just treat for these patients not without selection of PD-L1 expression. So radiation, the idea is, the model is that radiation induces both innate and adaptive immunity. We were able to show in this cohort that the patients who achieve a response, OCR and PRs, had an increase in the induction of type 1 interferon in the blood from baseline, while the other ones didn't. And also in a specific patients where we had tissue before and treatment, and we were able to follow his immune response in the blood, we showed that he had a specific induction of a CD8 T cell population in the blood, these clones that recognized a specific mutation, individual mutation he had in his tumor for karyoferrin A2. And as you can see, that these clones get induced after radiation ipilimumab and remain elevated as patient maintain response. So some preliminary evidence of radiation-induced neoepitopes. So the idea is that radiation works through viral mimicry in this mechanism of in situ vaccination, and as I've shown you before, through the induction of type 1 interferon, whether it's coming from the nucleus or the mitochondria, and that we can somehow reproduce clinically. and also as part of the DNA damage response, a series of survival pathways and many other repair pathways and so on are induced by radiation. And if there are mutations in those genes, there is now exposure of neoantigens for the immune system, as the example I showed you before. So both the innate and the adaptive immune response are elicited by in situ vaccination by focal radiotherapy. So what we were left to deal with is how to now optimize the immunogenicity of radiation. So we have to somehow figure out what is the best clinical setting, the best field size and site, the dose fractionation, the sequencing, and other variables. So we did a prospective randomized trial where we compare anti-PD-L1 and radiation versus anti-PD-1 alone. And the main endpoint was safety. This was in resectable non-small cell lung cancer. Of course, these patients are highly curable, so it was really important to demonstrate safety of irradiating the primary tumor, not draining nodes, even if proven positive, as well as objective pathologic response. And we were very pleased that with a dose of 8 grade times 3, there was comparable toxicity between the two arms, but significantly higher major pathologic response between, with the difference, it was statistically significant, 6.7% when durvalumab was given alone, anti-PD-L1, versus 53% when combined with radiation to the tumor only. And then if you remove the EGFR positive cancers, you can see even more of a gap, 8% versus 75%. So what I think was really important from this experience is that because we were treating the tumor but not the draining node, even when the draining node were proven to be positive in mediastinoscopy, like in this patient, we could test whether the combination was with radiation had more systemic effects. And in fact, in 13 patients in this series had nodes proven by biopsy to be positive before treatment. And in the arm that received just durvalumab, only 1 out of 7 got a major pathologic response, while when we combine with radiation to the tumor, not to the lymph nodes, 66% had the response outside the field. So what is the message here? Of course, this could be considered an increase of the systemic response through radiotherapy to one side. So not exactly an abscopal effect because they also have a systemic drug, but also the learning here is to confirm the preclinical data that in fact maybe is a good idea when you use radiation in combination with immunotherapy to exclude the draining nodes. And this is data that Ari Marciscano is now working with us had generated when he was at Hopkins, and he had a model of colorectal cancer that was engineered to overexpress OVA to make it more immunogenic. And he was able to show that if he was irradiating just the tumor, the light line, versus he could in fact get a prolongation of survival in this immunogenic model where radiation was in fact helping inducing an immune response. And then if he was adding anti-CTLA-4, removing one of the breaks in the immunosuppressive setting of the established tumor, he would have a very remarkable response and improvement on survival only when he was excluding the lymph nodes from the radiation field, because when the radiation field included the lymph nodes, there was no difference compared to anti-CTLA-4 alone. So the message is to avoid including the nodes, and maybe he can explain when radiation was combined, chemoradiation was combined with avelumab in the standard dose and fractionation with including of the node, the draining nodes in head and neck cancer. They couldn't see any difference in progression-free survival and overall survival. A couple of negative studies into this regard, but this experience in a smaller series where in Oregon, where they studied the combination of neoadjuvant immunoradiotherapy before surgery, and they just treated the tumor. So the primary target was just the tumor itself with no margins, very tight on the tumor, and excluding the draining lymph nodes, they started seeing a signal. And once again, keeping in mind that this is breaking some rules in radiation oncology, just when the immunotherapy is used in combination with radiation. So a lot of debate about dose and fractionation. And our group shown that, in fact, there is possibly a mechanism to explain what I showed you before, that a single dose has an inferior effect compared to 20 gray or 30 gray compared to 8 gray times 3. And the paper of Claire Van Poeybach shows it in detail, but the punchline is that possibly one of the mechanisms is the induction of TREX1, which is an exonuclease that will remove the substrate, so this fragment of DNA that somehow fuel SIGA-STING and induction of interferon. And in fact, when she knocked down TREX1, you can see that, first of all, the successful knockdown after 20 gray, so he was able to abrogate TREX1, and then she was able to recover the production of interferon in the knockdown setting. And this was confirmed by a clinical study where they reviewed a series of, in a phase 1 trial, multi-institutional phase 1 trial, patients with different malignancies that had undergone radiotherapy and pembrolizumab. And while the response rate was not that high in this trial, what they were able to show is that the patients who had undergone SBRT and pembrolizumab who had a response were in fact more likely to have, so these are the responses, low TREX1 and high DNAs. So which is the other enzyme, the opposite enzyme. So confirming in the clinic what we've seen preclinically. And this dose and fractionation of 8 gray times 3 seems to be successful. This is a convergence of the data from the Netherlands Cancer Institute in non-small cell lung cancer and the data from MDH in Welsh data, where he used often 8 gray times 3, but also he used other fractionation in series. But when they combine these patients who had treatment to one lesion during anti-PD-1 and with pembrolizumab, they were able to show an impact on survival, and practically for every subset in a subset analysis, they consistently adding radiation to one lesion. And in the MD Anderson series, sometimes they treated more than one lesion, but leaving other lesions untreated. But consistently, the addition of radiation was associated with better outcome. And again, same data, this time not randomized, but in a phase 2 feasibility in phase 2 trial, where they combined both EP and Nivo, and again, the same dose and fractionation, 8 gray times 3, in the setting of 2 different and difficult diseases, metastatic microsatellite stable colorectal cancer and metastatic pancreatic carcinoma. As you can see, disease control rate of 25 and 20% respectively. Then you look at the patients who were able to also receive radiation. The design was to receive first immune checkpoint blockade with ipi/nivo and then radiation. But if you can look at the patients who were able to complete radiation, a remarkable increase in disease control based on this protocol. And then the interesting preclinical clinical data that could inspire more preclinical studies, because they were able to show the pre-treatment in the initial biopsy, there were more natural killer cells and NK cells in the patients who had either stable disease or response to the combination of immune checkpoint blockade with ipi and nivo and radiation compared to the other ones. And also they were able to show an increase in RNA from retroviruses among the patients who had the response, suggesting that potentially radiation can in fact induce the expression of these epitopes and trigger a tumor-specific immune response through this strategy. So an issue that keeps coming up is that of sequencing. And I think we have to give some serious thought. The next speaker, Dr. Samir N.Kleif, published a beautiful paper in Nature Immunology where it was not using radiation, it was using a cancer vaccine, and showed that how the sequencing of PD-1 blockade made a difference on the efficacy of the vaccine in different models. And in fact, if given before, it would abrogate anti-tumor immune effects of the vaccine. Conversely, if given after, it will synergize with the vaccine. So the idea is that you could interfere with cross-priming by giving anti-PD-1 before. And this was confirmed by work done by the group of scientists at Regeneron that just compared in a model of colorectal cancer, giving a day after radiation versus just before radiation, anti-PD-1, and we're able to show a difference in the percentage of mice with tumor-free, not only with this model of 2 tumors on the side of the mouse. The advantage of giving anti-PD-1 after radiation was consistent both in the primary and secondary tumor and reflected on survival. So the dotted line is after versus the continuous line is before. So what other variables should we have in mind when we want to optimize the immunogenicity of radiation? This is a nice paper that came from University of Michigan on radiation to the liver metastasis. We know that patients who have liver metastasis presentation have a different T-cell signature score, so usually inferior, as you can see here, across tumors, prostate, lung, melanoma, colorectal, breast. So they have more resistance to immune checkpoint blockade. It's much more difficult to immunize them. And these investigators were able to show a quite elegant set of experiments that, in fact, once you have colonization of tumor cells in the liver, these tumor cells are capable to educate these myeloid cells to, in fact, render them a immunogenic filter, immunosuppressive filter, sorry, because they siphon from circulation the activated CD8 T cells, and they utilize fast ligand signaling to delete the tumor-specific T cells. So the same authors show that, in fact, if you radiate in a model of metastatic tumors in the liver, first the metastasis, you recover response to anti-PD-1. So the idea is that you can insert radiation as a mechanism to enhance immune checkpoint blockade by doing stereotactic ablation of liver metastasis, something we are more and more proficient at doing. And by doing so, interfere with this mechanism of immune suppression of this subset of myeloid cells and recover the response to immune checkpoint blockade. And then finally, I want to get your attention on this very nice paper that Stephen Shaw published in his group from Cedars-Sinai in LA, where they show that just manipulating the balance between commensal bacteria and fungi in the bowel of mice modify the sensitivity to radiation. So by giving antibiotics that reduce the diversity and the quantity of the normal flora in the gut, and making the fungi predominate, they will reduce the immune response. So all of this is really food for thought when we combine treatment. Maybe antibiotics may play a role as well. So the implication for trial designs to best exploit radiation immunogenicity are to use the tumor as a source of neoepitopes, so to favor the neoadjuvant and metastatic setting when there are tumors in place compared to the adjuvant setting, stay very focused in preventing overlapping toxicity, excluding the draining nodes, and favor hypofractionated dose regimens. So we have been really consistently using 8 gray times 3 because it's safe and it seems to be powerfully immunogenic, but it could be maybe even less, or it could be potentiated to 8 to 10 gray times 5. And more studies are needed to understand the optimal regimen. The scheduling is slowly and gradually emerging as really key and seems to be important to possibly give anti-CTLA for first, but anti-PD-1 after radiation, at least after a few doses of radiation. And of course, to keep some attention on the data emerging preclinically and hopefully soon clinically on the host immune fitness in the microbiome. And my general message is really hopefully to recruit more and more new talent and expertise to study radiation effects on the immune system, including the beautiful talk we heard on alpha emitters that are a really important form of radiation. So this is our program with multiple PIs, but I'm particularly indebted to our patients, and I want to leave a few minutes for questions. Thank you very much.
Thank you very much, Dr. Formenti, for a very comprehensive and very informative talk. I think we all learned a lot from your presentation, and I have a couple of questions, and I also would like to encourage all participants to send the questions via chat. If you are just raising your hand, I think neither speaker nor me can really see your hands, so better just to send questions directly so we both can see it. So I would like to refer to your introductory part, Silvia, where you mentioned that abscopal effect is rather rare. But then actually you demonstrated in very elegant and comprehensive manner that in fact abscopal effect is can be observed in patients maybe more often than everyone would expect. So what do you think for design of the trial for analysis of radiation therapy induced immune effect? Would you also suggest some biomarkers to predict this abscopal effect in patients? Apparently not all of them may develop this effect, right? So is there any hypothesis, any idea what kind of biomarkers through liquid biopsy or through a tumor biopsy can be potentially used to predict such of effect?
So thank you for your question, and maybe I didn't make it clear enough. The abscopal effect of radiation alone is rare. So because of the many immunosuppressive mechanisms that are in place for the time metastasis, or even a local advanced tumor or detectable tumor has established itself. So when you use the radiation alone, it's really difficult to irradiate one rib and expect that the spine responds, or irradiate one nodule on the chest and see a response in another nodule in the setting of just all recurrences of breast cancer, for instance. But if you use an immune checkpoint blockade, you can be fortunate enough to elicit an immune response in the irradiated tumor and then have shared neoepitopes or epitopes in other lesions. So once the T cells are activated, they recognize the other lesions. The challenge is that often in the setting of metastasis, there is enormous heterogeneity, and the other lesions that go, for instance, to the liver or the lung may have acquired mutations that are not present in the primary tumor. And even if you elicit a response to, against some epitopes, it may not be enough antigenic spread and information from the initial inflammation to eradicate systemic disease. So you do not see the abscopal effect. So the issue of heterogeneity in the setting of metastasis is enormous. And the possibility of resistance, even in a locally advanced tumor, because of heterogeneity and limited immune response to just some clones, is also very present. That's why you don't see enough immune response in general and abscopal responses.
A great answer. So actually, I also have one more question. We have only 1 minute, but actually it's quite interesting for me to know your opinion. It's more general question. There is like a few decades discussion about a bystander effect in tumors. Can we consider abscopal effect as just another side of bystander effect, but targeting not tumor cells, but rather immune cells? So basically the source is the same, or the molecules which induce immune system is the same, but the effector cells is not tumor cells, but rather immune cells. So do you see a relationship between these two different effects?
So the bystander effect is something that was shown in a different setting and didn't necessarily elicit an immune response. Was not mediated by an immune response, at least in the original demonstration. I think when we're talking about abscopal effect, and we try to mutuate the term from Dr. Moll, that we introduced in 1953, is really a setting of two nodules that have both escaped, or multiple metastases that have escaped the immune system in a live individual, in a carrier, in a human. And we try to reproduce it preclinically, but the human setting is much more complex, and those nodules have gone through immune editing to continuously escape the immune system, also have some baseline recognition of the immune system, just not successful enough to reject them. And is a much more complex effect that, a cellular bystander effect, whereby you have sensors, you have cells that are not irradiated that sense the effect of radiation on irradiated cells. I think there is a complexity of circuitries of immune response and immune tolerance that are elicited in the setting of metastasis that we're all trying to detect and understand better.
Great. Thank you very much for your comprehensive answering on the questions. There is also additional questions, but probably you can also, Michelle, send this question privately to the speaker, and because unfortunately we are a bit short in time. Thank you again very much for your presentation and for question answer session. And we are going to the next speaker, Professor Samir N.Kleif, who is an immunologist and immune therapist from Georgetown University. Professor N.Kleif will talk about novel agents and emerging concepts in immunotherapy. We are looking forward for your talk, Professor N.Kleif.
Thank you very much. So what I'm going to be talking about is kind of novel approach for immunotherapeutic intervention, particularly in utilizing novel agents. And what I mean by novel agents, mostly signaling reprogramming agents. So we've heard about the previous two talks about how radiation therapy could manipulate the tumor microenvironment. I'll talk a little bit more about how we're now thinking of reprogramming T cells. So these are my disclosure. Now, in general, T cell agonists are many, and we know that when you engage T cell with a co-stimulatory molecule, it activates the T cell. But the issue is that T cell always get committed to an effector phenotype and then terminal differentiation. The issue when we look at the linear proliferation differentiation of T cell, it always goes from the naive thymus into naive, into TSCM, into TCM, which is central memory, effector memory. The most important though is at the end of this, the T cell gets terminally differentiated and goes away, it dies. And most of our approaches currently lead to that terminal commitment, or the commitment, linear commitment of those T cells to differentiate and go away. One of the major problems currently we are facing in immunotherapeutics, whether T cell therapy or therapy in general, is T cell exhaustion. Because when T cell gets exhausted, then we lose its effect. And again, since we're committing this T cell into a linear differentiation and T cell exhaustion, then we're losing most of our cells that technically we could use in the future. So what we started looking at different signaling pathways within T cell and see how each one of them, because this is a science that's not really very clear, how each one of them affect the differentiation of T cell, and also how we can potentially use those for therapeutic advantages. So we started with looking at the MEK pathway. And the reason we wanted to look at the MEK pathway first, although we were looking now at multiple pathways, is that when we activate a T cell, it leads to co-activation of the MEK pathway. And when you activate the MEK pathway, downstream of the MEK, there's ERK1, there's cyclin D. Those two lead to persistent mitogenic stimulation with increased cell cycle progression. That increased cell cycle progression leads to, plus that cyclin D1 inhibit PGC1 alpha, both lead to metabolic exhaustion lead to T-exhausted phenotype, and hence we lose the T cell functionality. So the question that we thought of is, if we target this pathway while activating T cell, can we decrease T exhaustion? Can we make the T cell a better T cell? Can we lead to a super T cell potentially for therapeutic intervention? So part of this presentation has been already published, I think 2 or 3 months ago at Nature Immunology. And here's what we've done. So Vivek, Seema, Anul, and Mika had worked on this very diligently with a very interesting outcome. So what we found is, indeed, if you give a tumor to mouse, we vaccinated only to generate T cell priming, and then we give it with MEC. So we give MEC, nothing happened. However, when we give MEC with the priming agent, we enhance the effect of T cell significantly. And you could look into the escape plot. The upper part is tumor size, the lower part is survival. We clearly found, and white is alive, dead, black is dead. We clearly found that when we added MEC to the priming agent, it enhanced the anti-tumor immune effect very significantly. And that's done in multiple different tumor models, and all of it reproduced exactly the same way. Now, when we started looking into the tumor microenvironment and looking what happened to this T cell, what we found is that when we're giving, when we're inhibiting MEC with the priming agent, what we're finding is that T cell infiltration is enhanced, and antigen-specific T cell infiltration is enhanced, and the activity of T cell is enhanced. So it looks like eliminating MEC pathway is increasing the T cell functionality. Now, not only with a priming agent, but even without priming agent, if we look at what happened to MEC, it looks like it enhanced the activity of vaccine, or the priming agent is almost the same. So the question, is it really leading to the inhibition of exhaustion as we hypothesized when we started manipulating those cells? So when we looked further at markers of exhaustion, we found that all marker of exhaustion has decreased. All activation markers have increased. So it looks like, yes, we are decreasing exhaustion and increasing activation in a very specific manner. So is it metabolically driven? So when we started dissecting this, and Vivek Verma did most of this metabolic work, we found that, yes, if you look at the mitochondria, with or without inhibition of MEC, you can see the mitochondria is becoming more impacted, extremely active. And if you look at the mtDNA, we found that this is increasing. And if you look at the mitoFM, we looked at it is very significantly increasing. So it looks like the mitochondrial fitness and the mitochondrial metabolism is enhanced. And that is clear from when we started looking at the mitochondrial function and metabolism. Excuse me. We found that the oxygen consumption rate within T cell is significantly increased. The spare respiratory capacity is significantly increased, but very interestingly, that the ECAR, which is extracellular acidification rate, has decreased. So it looks like as if we are shifting the Wahlberg phenomenon from to the left, technically. So we're making the cell more dependent on mitochondrial fitness, and that pyruvate is enhanced in its uptake, that decreased lactate, which means that the whole T cell mitochondrial, the whole T cell metabolism is becoming more fit for a better functional T cell. So looking at this, when we looked at the fatty acid oxidation, we found that the enzyme for fatty acid oxidation uptake is enhanced, and the lipid uptake is clearly increased. So it looks like we are enhancing fatty acid oxidation. And if we look into the inhibition of the fatty acid oxidation by palmitate, we look, this is the cells with GP100, and these are the cells with GP100 plus MEC. So the MEC enhanced the OCR, However, when we inhibited the fatty acid oxidation, OCR is gone. So it looks like, yes, it is dependent on both fatty acid oxidation and pyruvate uptake. And that is represented in this plot here. So now, if we look at the pathway, is it coming through? So clearly then there's increased fatty acid oxidation, and that increased fatty acid oxidation led to enhancement of metabolic fitness. So is it going through this pathway? And very much so. We found that PGC1 alpha is increased. We found that SIRT3 is increased, and whether this is in percentage of or MFI. So our prediction was, if we activate the T cell in the absence of this pathway, those very critical molecules are enhanced, leading to increased fatty acid oxidation and enhancement of metabolism. So what are these cells? What we found is that what we were generating, if we look at the markers of different type of cells, that the CD172 is enhanced, which means that it looks like there are some sort of reduction in exhaustion and enhancement of memory precursors. When we started looking further into phenotype, we found that it's increasing central memory, but also increasing T-naive cells. So it looks like those are becoming, rather than proliferating and going into terminal differentiation, T-cell exhaustion, they're acquiring higher level of central memory phenotype with a naive phenotype. And when we looked at my memory naive, including the CD95, CDL62L positive, we found that this also have enhanced, and the CCR7 enhanced. So it looks like it is more memory naive. Now, when we took them and looked at their metabolic profiling, we found that those cells are very unique, like they are different kind of subtype. This is the naive cells. These are the activated cells with an antigen, and these are the activated cells with an antigen in the absence of MEK pathway. So clearly they are looking from a lipidomic perspective and metabolomic perspective as distinct cell phenotypes. So they're not similar to any other of those phenotypes that are progressing within that linear progression. And if we look at the array of metabolites and lipids, we found that they are interestingly fit between the activated and the naive. So they created somewhere a specific phenotype that are not committed to that terminal differentiation, but stuck somewhere in the middle. And if we look at that, I mean, clearly that might be a stem cell memory phenotype, which is great, because this is exactly what we need. We need to create this depot because those cells can be regenerating, can survive for a longer time. They have much less death or apoptotic susceptibility. And hence, this would be a major depot of cells that could be important for cell therapeutics. So we looked into this. And what we found is, one, they increase their SCA1 expression, which means they are very naive. So it looks like they have that naive phenotype, but also they have TMRM, which means that they are really metabolically very fit. That's one. Second, when we started looking at their 62L positive, 44 positive, which means their memory, central memory phenotype, they are very high central memory phenotype. But the interesting part is they decrease a little bit of their central memory and enhance their naivety. So when we look into that linear direction, we found that those cells fit exactly in the middle. So what we're creating here is, by activating those T cells in the presence of absence MEK pathway, we're creating a highly regenerative T cells that are TSCMs, which are stem cell memory characteristics. Now, so do they have those characteristics? Can they regenerate? So looking into the KLF2, which is the renewal survival markers, we found that indeed they are highly regenerative. So yes, check, they do regenerate very highly. But second, which is as importantly, their ability to die is less because of annexin, and their ability to survive is higher BCL2 markers. So it looks like indeed we are generating central memory stem cells that are highly regenerative, highly survivable, and they have less death capabilities. So how do we generate them? Do we need to actually activate them at the naive level or at the activated level? And we looked into those because that's really interesting. In other words, if the cell is activated by or engaged, the TCR is engaged by an antigen, are they committed to die? Or we can rescue them? Or do we need to rescue them in a preventive way prior to their commitment to die? So what we did is we took PML cells, we either put them with IL-2 or activated them with GP100 or activated them with GP100 plus MEK. And as I showed you before, clearly we're increasing those stem cells. Fantastic. Now, if we took those cells, the ones that are active, so in other words, those cells were not activated before, we inhibited MEK while we're activating them. But if we take those now, and what we do is after we activate them for 48 hours, then we add MEK, what happens? And what we found is we lose that ability completely. So it looks like, yes, if the cells got engaged with an antigen, they are absolutely committed to go through that process of linear proliferation or linear differentiation and get exhausted and die. However, if we need to really rescue them, they have to be in the naive state. And as we know, tumors have lots of naive T cells anyway, so that can be done. So they're not only cannot be stem cell, but cannot be naive either. They lose that possibility because they're committed to drive forward. So how do they function? Are they functioning properly? And do they give us good potential outcome? So we did the same thing. We generated those cells with MEK inhibition, and we found that we have those high memory T cells. What we did now is we took those cells or those cells without MEK and we re-challenged them. And what we found that when we re-challenged them, those cells that were activated in the absence of the MEK pathway, they have way higher recall capabilities. So they are not only persistent, not only generating, but they're technically superior T cells. They are there for us whenever we need them to regenerate in a much more active way and much more powerful way. So accordingly, they are much better T cells. So to summarize, what we did is if you activate those T cells in the absence of the MEK pathway, it leads to enhanced metabolic fitness. It leads to induction of memory, leading to generation of stem cell, memory cell with much higher recall response. So can we test them in vivo now? So what we did is we did the usual ex vivo activation of T cell, and then we infused them into mice. And what we found, that's regular without MEK or without anything. And what we found is that if we do this, we're getting good response from the T cells. However, which is this, now if we activate with MEK, this if we do not activate with MEK. So clearly MEK enhances the ability of those T cells that are infused in mice to lead to much better anti-tumor effect. So what we did, so this is only GP100, this is GP100 with MEK. Now, if we take those TSCMs and if we take those cells and we deplete them from the TSCMs, we lose part of that effect. So clearly, one, MEK enhances the ability of those T cells to work much better in vivo, as we saw when we gave the MEK orally, by gavage to mice, but it enhanced the ability of those T cells to become superior T cells. And if we remove the TSCM, we lose part of that effect. So to summarize that, what we're seeing is that if we take it, if naive T cells get activated with an antigen, that what we see all the time, it commits itself to this differentiating effect, lead to T effector cell and then exhaustion. If we inhibit the MEK pathway, what we're leading is to generation of high level of stem cell depot that is leading to much better T cells, memory T cells with higher ability to recall, and accordingly, higher percentage of highly active, much better active T effector cells that leading to better effect, but we still have that depot to activate more. The second thing is that we discovered, and what we know now, is that really activation of the MEK pathway is an absolute committal to T cell differentiation. And this is where we can engineer pharmacologically to do that. So what we saw so far from a clinical use perspective, that ex vivo enhancement of T cells clearly can do better by inhibiting the MEK pathway. Can we now use it for potential combination of immunotherapeutics? So what we wanted to look into is OX40. And the reason we wanted to look into OX40 is, one, OX40 failed and failed miserably in the clinic, although it should work. And second, we found that combination of OX40 with PD-1 really antagonizes each other and lead to killing of the effect. So there must be, and that is what led to, of course, the death of OX40 almost, and many companies are removing it off the shelves. However, we believe that those agonists might be very good compounds. So why did we decide to look into OX40? So since MEK induces TSCM, OX40 is known to enhance memory. So we thought, could OX40 benefit from something like inhibiting the MEK pathways and do a better job in its clinical outcome? So we did the same thing. We took now enhance with MEK, but also with OX40. And we found very interestingly that adding OX40 further enhance OCR and SRC, but it flips ECAR. If you remember, I showed you ECAR goes down because of that Wahlberg shift, but it flips ECAR. So it makes it even better. So that might actually generate completely different type of T cells. However, those T cells are clearly better fit and may work better clinically. So which means that we are not only shifting the Wahlberg phenomenon, but maybe enhancing further the T cell functionality. So when we combined MEK, which is this, with OX40, it gave us very significant enhancement of T cell functionality in a very cold tumor, in this case, which is CC1. We've done that now in multiple different tumor types, whether cold or hot, and clearly that's giving us very interesting. I mean, this is something that you don't see much in cold tumors like TC1, where you have almost disappearance. Of course, here we stop therapy, so it goes up to no, but almost disappearance of the tumor, which we believe that this might be a very good potential therapeutic approach to OX40. And again, looking at the T cell infiltration, very high T cell infiltration, very high antigen-specific T cell infiltration, and it enhances further the recall of those T cells. So not only the OX40 enhances it, MEK enhances it, but OX40 gives it a better recall activation, and they do not die. They do not apoptose like when we combine the OX40 with PD-1. So there's no antagonism. In this case, we're leading OX40 to work by itself smoothly into enhancement of CD8 functionality. So looking into now summarizing this, what we found is MEK can change the phenotype, can reprogram the T cell from committal towards T cell differentiation and exhaustion into becoming a much better T cell and putting it in a TSCM phenotype, and which means that by itself could be used either as a combination to enhance immunotherapeutics or as ex vivo enhancement of T cell functionality. When we add a molecule like OX40, the MEK inhibition or the absence of MEK pathway makes that OX40 working a much better way, but leading to a better T effector cell that has all the elements of T effector, but in a much stronger perspective. So if we put the antigen with MEK, we enhance that depot, it leads to further recall. OX40 makes it even better. So we're currently working with NCI and AZ on putting together a potential combination of this MEK and OX40, one, and second, we're working with NCI to use MEK to see if we can manipulate particularly priming agents and make those effector in much better, enhancing tumor outcome and response. This is the team. So the people that worked on this project are Vivek Verma, who currently went as a faculty at Minnesota. He just left to be an independent investigator in Minnesota. Seema Gupta, who's a faculty in the lab, Mika McCutcheon, who's also a faculty in the lab, Pankaj and Nazli and Anur. Thank you very much.
Thank you very much, Professor Kleif, for interesting presentation. I'm not immunologist. I learned a lot from immunological topic today. So I think for me, it was really very interesting and exciting talk. And I would like to also congratulate you on launching of the clinical trial. I think we're all looking very much forward on the outcome. And I have one question related to the launching of this clinical trial, but probably rather to effect of MEK inhibitors, potential effect not only on T cells, but also on tumors. So you excellently demonstrated that MEK inhibitors is really critical for creating of this highly potent stem cell memory T cells through improvement of mitochondrial function, through activation of fatty acid oxidation. Those cells also activate KLF2 expression and so on. But do you think that the same feature can also happen in tumor cells, which make potentially those cells more complicated to cure?
No, it's completely different, because the effect, I mean, when that would be on tumor pathways are completely different, because tumor doesn't go through that particular differentiation pathway, one, and the metabolism of the tumor is very different than the metabolism of T cells, so it's not fully dependent on the same outcome of the tumor. One. Second, clearly, when we looked into mice in tumor microenvironment, T cells are surviving. They're becoming, this is in tumor microenvironment, they're becoming more regenerative. However, tumor cells are dying. So clearly your tumor cells are being killed. So the answer to your question is no, it's very different. Pathways and signaling.
Okay, great. Thank you very much. So apparently you have a lot of compliments from audience. So, and please, I would like to ask you, dear attendees, don't be too shy, ask the questions. And I also would like to ask you probably one short question. Can you also imagine that combination of MEK inhibitors for prevention of T cell exhaustion can be particularly important for instance, combination of immunotherapy with some cell toxic therapy like radiotherapy? Can you also imagine further development of?
No, absolutely. I mean, if you look at Silvia's talk, for example, which clearly demonstrate that radiation therapy is an immune modulator, and it leads to the vaccine effect. What we showed clearly is that the activation of T cells are important to post inhibition of the MEK. So that combination is an obvious combination. So any priming agents, including vaccines or otherwise, like radiation, would absolutely be a potential combination on that.
Great. Thank you very much. I appreciate your excellent talk, Dr. Kleif. And today we are done with the first part of our afternoon session. We are looking forward to see you back, I believe, in 20 minutes. So we have 20 minutes